Dear colleagues, this is an edited video of a Phaco surgery with weak zonule, but I didn't use any capsular tension ring in this case. The main incision has been placed at a selected site. Viscoelastic substance has been injected into the anterior chamber. This is HPMC. Now see, as I incise the capsule, the whole lens moves. This is the sign of weak zonule. You should make out as you incise the anterior capsule with your cystitome. The whole lens moves means the zonule is weak. Now you can use a CTR, but in this case I wanted to see if I can manage this case without using capsular tension ring, and I succeeded. The capsular axis has to be done very gently. We cannot give any jerky pull. It should be very slow, steady movement. The axis has been done nicely. Now hydrodissection is being attempted. One side port only has been made in this case, that is in the left side of the main incision. Here it is. Now hydrodissection is to be done. A 27 gauge cannula is used to do the hydrodissection. Now see what happens. As I attempt hydrodissection, the fluid wave didn't go to the other side. I tried 3 times, it didn't go. Now I go to the other side, and as I try once, it came to this side. So hydrodissection has been done, but in this case I do not want to rotate the nucleus, because I thought if I try to rotate the nucleus, I may cause some stress on the zonule, and the remaining zonule can tear. There can be tear of the remaining zonules. Now I go bevel down. Now in this case I am trying to do the surgery with which I use in no hydro technique. Here it is. Embed the nucleus, and this is the fast chop, and be here for some time so that the fluid goes posteriorly. Now this is the 7 o'clock chop. I don't rotate the nucleus. Yes, the 7 o'clock chop has been successful, but because there is little space, it doesn't come. Now I see that I can rotate the nucleus a bit, and this is the 4 o'clock chop, and this free nuclear fragment now comes, and by this time hydrodissection has occurred nicely and the nucleus is rotating freely. Now one by one I chop the nucleus and I emulsify the fragment. Now here it is. I could not chop this fragment, let it be there. Now I chop here and again here. I keep the piece at 6 o'clock to support the nucleus. The fragment at 6 o'clock I do not remove. Now I support the capsule with the chopper and I remove this nucleus, fragment of this nucleus. Now this is the last nuclear fragment. The thick epinucleus is supporting the back. Now I can see the margin of the rhexis, and I see that there is enough strength of the zonule, and I need not put a CTR in this case. However, I become very cautious while removing this thick epinucleus. I wait for some time, and when I can see that the rhexis margin is intact all around, I emulsify this epinucleus and remove it. Now before I come out, I ask my assistant to inject. I hold the needle, cannula, and I ask my assistant to inject viscoelastic substance. I stop irrigation, the bag becomes full of this viscoelastic substance, and then I come out. That's it. I have supported the bag nicely with viscoelastic substance. Now I am going to remove the cortical matter gently, taking care of the capsular bag. I want to see that the bag remains there. It doesn't move. So we must be very careful, very slow, very steady, and we must keep our reflexes very sharp in such cases. And this is the part of the cortical matter. On the other side, I am using a 23 gauge Simcoe cannula to very gently remove the cortical matter, and I could do it well. Now that's it. The capsule is clean. There is not much of cells, so I inject viscoelastic substance, and in this case I am using a hydrophilic acrylic intraocular lens. The lens is placed in the capsular bag. The lens is dialed and the haptics are placed at desired meridian. Now I want to remove the viscoelastic substance thoroughly, again taking care not to catch the capsule at any place. I must not catch the capsule, not even the capsular rim, and we must not pull the capsular bag with the Simcoe cannula or aspiration port of the bimanual IA. So the viscoelastic substance is being thoroughly cleaned. Now I take care of the depth, antechamber depth, and when I see that the antechamber is sufficiently deep, then only I go to aspiration mode. Because I have only 2 ports, I take care of that. That's it. The case is almost over. This is moxifloxacin, and the only one side port that was made in this case is hydrated. And now this is the final wash. Here it is. This is the final wash under high magnification. I can see that the viscoelastic substance sticking to the posterior capsule comes at this time when I use higher magnification. In lower magnification I cannot see. Yes, the viscoelastic substance that was sticking to the endothelium has come out. Now the case gets over. Thank you very much for watching. Hope this video will help in developing your surgical skills.